A methodological guide for implementing and interpreting results of probabilistic analysis. This presentation is based on our publication in the Expert Review of Pharmacoeconomics and Outcomes Research. I thank my co-authors. My colleagues and I have published several articles related to probabilistic analysis before writing this methodological guide article. My co-authors and I had extensive discussions of methods for probabilistic analysis during preparing these manuscripts. Also, we thank the anonymous peer reviewers of this manuscript for their constructive comments and suggestions. The present article reflects our understanding of probabilistic analysis, with incorporation of the feedback received. Abbreviations used in this presentation. The outline of this presentation. Introduction. Deterministic analysis considers only the point estimates of model parameter inputs. Probabilistic analysis is often referred to as probabilistic sensitivity analysis, PSA. Parameters included in probabilistic analysis are given a probability distribution to account for uncertainty around their mean estimates. Probabilistic analysis is often employed through Monte Carlo simulation and has become the recommended approach by many agencies and organizations. Although probabilistic analysis is used extensively in health economic evaluations, it is not always properly implemented or interpreted. There is limited detailed guidance on the conduct and interpretation of the results of probabilistic analysis within health economic guidelines. More importantly, health economists may not fully understand concepts of probabilistic analysis because its limitations are rarely discussed in the literature. This paper aims to provide methodological guidance for implementing and interpreting probabilistic analysis for health economists and stakeholders involved in health policy and decision-making. I will provide an overview of methodological issues related to common practices in probabilistic analysis. At the beginning of each subsection, I will introduce the key points. I will elaborate a little bit after the key points. You can find more details in our publication. Sampling distribution of a sample mean versus a sample distribution. Key points. In probabilistic analysis of model-based economic evaluations, input parameter distributions should be based on the sample mean and standard error, rather than the sample mean and standard deviation. The distributions of parameter input estimates used in probabilistic analysis represent the distributions of parameter input sample means, not the distributions of samples. When model parameter estimates are based on large sample sizes, according to the central limit theorem, it may be appropriate to define any input parameter as having a normal distribution, using sample mean and standard error. In practice, health economists may use sample means and standard errors to fit other types of distributions when considering the nature and boundary of data, such as gamma distributions for costs to prevent negative values and beta distributions for health state utilities to ensure a range from 0 to 1. It would be incorrect to derive model parameter distributions based on the sample means and standard deviations, instead of standard errors. It is important to distinguish variability, heterogeneity, and structural uncertainty from parameter uncertainty. Variability refers to the variations of outcomes of different patients. Clinical heterogeneity includes different patient characteristics, age, sex, disease severity, comorbidity, which may be associated with different treatment effects and health outcomes. Clinical heterogeneity can be explainable, and stratified probabilistic analysis may be used to address the heterogeneity of study populations. Structural uncertainty is related to model structure and assumptions and may be addressed by scenario analysis. Willingness to pay threshold, key points. The willingness to pay threshold generally refers to the monetary value of marginal health gain and is defined as the additional cost per one Corley gained, increments. Therefore, using the willingness to pay threshold is appropriate for the cost-effectiveness acceptability curve when comparing two treatment strategies. In the case of multiple strategies, willingness to pay refers to the willingness to pay per Corley for the total number of Corleys, not increments. However, HTA agencies or stakeholders typically do not vary willingness to pay thresholds for different scenarios. When an economic evaluation compares two strategies, intervention and comparator, the cost-effectiveness acceptability curve is derived from the joint distributions of incremental costs and incremental Corleys estimated by Monte Carlo simulation. If the intervention has a positive incremental net monetary benefit calculated by the first formula, it indicates that the intervention is cost-effective versus the comparator at that threshold. For a decision analytic model that compares three or more strategies, health economists generally aim to identify the optimal strategy with the highest net monetary benefit using the second formula. The implications of willingness to pay thresholds in two formulae are different. The willingness to pay threshold for two strategies in the first formula refers to the willingness to pay per Corley gained, whereas the second formula reflects the willingness to pay per Corley for the total number of Corleys. The willingness to pay threshold is a budget threshold and generally refers to the monetary value of marginal health gain, and is established by decision makers' willingness to pay preferences per Corley gained by using direct method. Therefore, commonly used willingness to pay thresholds are best suited for comparing two strategies using the first formula. We are not aware of any published articles that discuss whether the same willingness to pay threshold remains appropriate for comparing multiple strategies using the second formula. A commonly used decision framework in Canada presents the uncertainty from probabilistic analysis qualitatively into 5 descriptive categories based on the cost-effectiveness acceptability curve. Highly likely to be cost-effective, moderately likely to be cost-effective, uncertain, moderately likely to not be cost-effective, or highly likely not to be cost-effective. This framework is best suited for comparing two strategies and may not be directly applicable when comparing three or more strategies. Cost-effectiveness acceptability frontier. Key points. The cost-effectiveness acceptability frontier displays the optimal strategies across a range of willingness to pay thresholds, along with the probability of each being the optimal strategy at these thresholds, within a single curve. The cost-effectiveness acceptability frontier has two advantages over the cost-effectiveness acceptability curve. 1. Connects the representation of uncertainty and the identification of the optimal strategy, and 2. Simplifies the curve and enhances comprehension, especially in scenarios with three or more strategies. The cost-effectiveness acceptability curve presents the probabilities of health technologies being cost-effective at a range of willingness to pay thresholds. While the cost-effectiveness acceptability frontier curve presents the uncertainty of the optimal alternative over a range of willingness to pay thresholds. In principle, the optimal strategy should be based on the highest expected net monetary benefit, rather than the highest probability of being cost-effective. Although widely used, the cost-effectiveness acceptability curve does not explicitly show which strategy is optimal at a given willingness to pay threshold when multiple strategies are compared. The cost-effectiveness acceptability frontier may address this limitation by incorporating both the strategy with the highest expected net monetary benefit and the probability of being the optimal strategy in a single curve. The fractional exhaled nitric oxide, FeNO, test to support asthma management for children may be used to illustrate the differences between the cost-effectiveness acceptability curve and cost-effectiveness acceptability frontier. Compared with standard care, pheno-based management resulted in higher costs and greater CALIs, and the associated incremental cost-effectiveness ratio, ICER, was about $104,000 per CALI gained. The cost-effectiveness acceptability curve and cost-effectiveness acceptability frontier are presented in this slide. The cost-effectiveness acceptability curve showed that the probability of pheno being cost-effective increases with increasing willingness to pay thresholds, and pheno had a greater than 50% chance of being cost-effective when the willingness to pay threshold was greater than $76,000 per CALI gained. However, the cost-effectiveness acceptability frontier showed that pheno was the optimal strategy only when the willingness to pay threshold was about $104,000 or greater. Therefore, when the willingness to pay threshold ranged between $76,000 and $104,000, despite the lower probability of standard care being cost-effective compared with pheno, standard care remained the optimal strategy. Value of information analysis. Key points. Value of information analysis provides a framework to address whether a health technology should be adopted or reimbursed, whether more evidence is needed to support this decision in the future, and the optimal study design for future studies. However, uncertainty from the model structure and assumptions are not captured in value of information analysis. The expected value of perfect information, EVPI, is the difference between the expected net benefit with perfect information and the expected net benefit with current imperfect information. The EVPI may quantify the probability and consequences of erroneous decision making through the net monetary benefit approach at a range of willingness to pay thresholds. After the EVPI per person is generated, the population EVPI can be calculated. While the EVPI suggests that future research may be worthwhile, health economists may use the expected value of partial perfect information, EVPPI, to identify which uncertain parameters should be explored. The population EVPI and EVPPI provide the necessary condition for conducting further research, and the expected value of sample information, EVSI, may be used to establish a sufficient condition for further research. However, health economists need to understand the underlying assumptions of value of information analysis to ensure that the decision model is accurately structured and the uncertainty around each of the parameter inputs is appropriately characterized. Uncertainty from model structure, methodology, and assumptions is not captured in a value of information analysis. I will explore technical aspects not widely addressed in the current health economics literature. Number of iterations required in Monte Carlo simulations. Key points. Probabilistic analysis involves a random sampling process through the Monte Carlo method, and it is inevitable that potential errors will be introduced due to the finite number of simulations. Health economists may use incremental net monetary benefit to assess model convergence and determine the number of iterations required by evaluating whether the 95% confidence interval of the incremental net monetary benefit for a given number of iterations includes 0 or not. In addition, health economists may choose the precision level and determine the number of iterations required based on the Monte Carlo standard errors of incremental costs and incremental CALIs. If health economists use an arbitrary number of iterations, the Monte Carlo standard errors of model outputs should be reported. A method using incremental net monetary benefit to assess model convergence has recently been proposed. In summary, if the 95% confidence interval of the incremental net monetary benefit for a given number of iterations does not contain 0, No further simulations are required since additional simulations would unlikely change the decision. Conversely, additional iterations are required to improve precision until the 95% confidence interval of the incremental net monetary benefit does not contain zero. Health economists may also use the Monte Carlo standard error to determine the number of iterations required to generate independent samples in economic evaluations. Monte Carlo standard error is calculated from the standard deviation of the model outputs divided by the square root of n iterations. Since incremental costs and incremental CALIs are the primary outcomes in economic evaluations, focus on these two outcomes may be used to determine the number of iterations. Health economists may then select the number of iterations with acceptable accuracy. We may calculate the number of iterations required by setting a pre-specified Monte Carlo standard error. We can assume that Monte Carlo standard error is the same as the maximum rounding error used to present results. We can also define the acceptable accuracy based on the justifiable methods. In practice, health economists may also compare the model outputs with the Monte Carlo standard errors. If the magnitude of a model output is much greater than its Monte Carlo standard error, it suggests that the error due to the number of simulations has minimal impact on the value of the estimator. Therefore, the simulation based on the current accuracy level may be acceptable and the number of iterations is likely adequate. In contrast, when model outputs are very small, such as incremental CALIs are close to zero, a larger number of iterations may be required. At the very least, if health economists do not calculate the necessary number of iterations prior to conducting Monte Carlo simulations and rely on an arbitrary number, the Monte Carlo standard errors of model outputs should be reported. Implications of a large or small degree of uncertainty of results. Key points. Significant parameter uncertainty suggests that the true ISA or incremental net monetary benefit may differ substantially from current results. When parameter uncertainty is small and the model is based on high-quality data, health economists may expect the cost-effectiveness results to be close to the true values. Some published economic evaluations use probabilistic analysis in the reference case, but do not present the uncertainty around the mean values of model results. Health economists should present the 95% credible interval, 2.5% to 97.5% percentile, or standard deviation for probabilistic model outputs in addition to the mean estimates. Since probabilistic analysis uses the distributions of sample means as model inputs, the standard deviations of probabilistic analysis model outputs may be regarded as equivalent to the standard errors in an economic evaluation using individual level data. The parameter uncertainty of both incremental CALIs and incremental costs may be small. In this case, it cannot be concluded that the incremental CALIs, incremental costs, and ISA in the present analysis is close to the true values because probabilistic analysis results mainly reflect the precision of the results and not the validity of findings. For example, model parameters based on large retrospective registry data may be precise with small variance, but these parameters may be subject to higher risk of bias compared with controlled clinical studies. Health economists may expect the cost-effectiveness results to be close to the true values only when the model is based on high-quality data and the parameter uncertainty is small. Credibility and meaningfulness of small incremental CALIs. Key points. Small incremental CALIs, such as less than 0.002, are often not clinically or statistically meaningful. In these scenarios, presenting the main findings using the incremental net monetary benefit is likely a better approach than the ISA. When the difference in CALIs is inconclusive and likely unmeaningful, stakeholders may use other factors, costs, equity, accessibility, to support their decision-making. We provided two examples that the width of the uncertainty intervals are likely large relative to the mean value and cross zero. Assuming that the model captured the true difference between treatments, the true value of incremental Carleys would likely fall in an uncertainty interval ranging from a negative value to a positive value. In this circumstance, health economists may focus on the distributions of the incremental net monetary benefit in the probabilistic analysis results instead of the ISA because of the considerable probability of having negative incremental Carleys. We are not aware of any studies that discuss clinically meaningful differences in Carleys. Assuming a small difference in Carleys between two health technologies, it may be expected that the changes are driven by improved health state utility or prolonged survival. The minimally important difference from patients' perspective is the smallest difference in score in the domain of interest which patients perceive as beneficial. It has been found that the mean minimally important difference in the short form 6D and the Health Utilities Index 2 or 3 health utility was 0.03. Therefore, if health technologies have the same survival over a 1-year time horizon, the minimally important difference in Carleys would be around 0.03, whereas if the time horizon is 10 years, the minimally important difference in Carleys would increase to 0.3. It may also be assumed that the Carleys difference may be largely driven by differences in survival. Given that most survival analyses use 1 day as the time unit, it may be assumed that a clinically meaningful difference in survival is at least greater than 1 day. If the average health state utility is about 0.7 and 1 day is the minimal difference in survival, the clinically meaningful difference would be around 0.002 Carleys. The aim of minimally important differences from a societal perspective is to understand meaningful changes that would allow a patient to return to employment, and the degree of change that is required for adjustments in healthcare policies or produces a claim closure for payers. When interpreting the minimally important difference in Carleys from a societal perspective, the minimally important differences may be smaller for a large population compared with a small population. Handling model parameters with unknown variance, key points. When the variance of model parameters is not reported, clinical judgment is recommended to determine the appropriate size of the standard errors in relation to the mean, rather than arbitrarily defining variance. When overall parameter uncertainty is large, or many probabilistic distributions are arbitrarily defined, health economists may consider assigning distributions to a set of key parameters to understand the drivers of parameter uncertainty. Publications used to source potential model parameters may only report point estimates without any information about the variance around the estimate. Clinical judgment is recommended to determine the appropriate size of the standard error in relation to the mean. Health economists may consider using 10% of the mean estimate as the standard error of the corresponding parameter for probabilistic sensitivity analysis. When overall parameter uncertainty is potentially large, or when many probabilistic distributions have been arbitrarily defined, health economists may focus on assigning distributions to a set of parameters of interest in the probabilistic analysis, rather than for all parameters. In this case, parameters that are not of interest are considered as a set of fixed values that are controlled for. The approach of assigning distributions for selected parameters may help decision makers more accurately understand the drivers of parameter uncertainty and the robustness of the cost-effectiveness estimates. I will present considerations for nonlinear models and evolving methods in probabilistic analysis. Expected values of a nonlinear model based on varying sample sizes from the evidence, key points. In a nonlinear model, both the expected values of the inputs and their variance may significantly impact the expected values of the outputs. We illustrate how variance of input model parameters may impact model outputs in a nonlinear model. For a one-way Markov model, individuals may only progress to worse health states and cannot return to better health states. The distributions of transition probabilities based on a small sample size is generally associated with greater gains in life years. When to be cautious of probabilistic analysis results. Key points. Health economists may conduct deterministic analysis in addition to probabilistic analysis to explore the robustness of cost-effectiveness results in the following conditions. 1. When the variance of key model parameters is arbitrarily determined in nonlinear models. Then the expected values of model outputs may be unreliable. And 2. When key model parameters have wide, asymmetric confidence intervals, health economists should consider plausible distributions for probabilistic analysis. It is not always appropriate to use probabilistic analysis to estimate the expected cost and health outcomes or the ISA. Earlier publications have illustrated that deterministic analysis is associated with greater bias in a nonlinear model under an implicit assumption that the distributions of model inputs represent the true model parameters. However, there is no definitive answer for which analytic approach, probabilistic or deterministic, is associated with less biased estimates. Recent studies have found that probabilistic analysis may be associated with greater biases in model inputs, such as risk ratio, and model outputs, generating extreme values that may bias results, as illustrated above, compared with deterministic analysis. Factors impacting parameter uncertainty. Key points. Modeling methods impact the degree of parameter uncertainty. Health economists need to understand the modeling methods used to accurately interpret the results of probabilistic analysis. In addition to the variance of model inputs, modeling methods also impact the degree of parameter uncertainty. Unique parameters, those used in one strategy of the decision model, but not in others, such intervention costs and unique health utilities, are often key factors that impact parameter uncertainty. A two-level simulation may be appropriate for time-to-event data. Extended applications of probabilistic analysis. Key points. Probabilistic analysis methodology has evolved in recent years. Health economists may consider applying more recent methods when appropriate. Recently, there has been discussion in the literature about extended applications of probabilistic analysis and the best approach to incorporate parameter uncertainty in health economic models, such as using prediction interval in meta-analysis for treatment effect, modeling unreported correlated parameters from summary statistics, and sampling ordered parameters. Although these methods are currently not routinely used, it is valuable to understand them and consider their application under certain conditions. I will provide the highlights of this article. Continue. I now conclude this article. A deeper understanding of probabilistic analysis methods, its limitations, and appropriate use will allow health economists to address parameter uncertainty more effectively in health economic evaluations, which is essential for informed policy and decision-making. The timeline of the milestones of this study. Thank you.